failure with preserved ejection fraction, or HFpEF, is a diagnosis made using patient history, echocardiography, and biomarker data. Hello, my name is Matthew Connerman, and I am an advanced heart failure specialist at the University of Michigan. Today, I will be reviewing the results of our manuscript entitled Specialty-Based Variability in Diagnosing and Managing Heart Failure with Preserved Ejection Fraction. This manuscript is set to be published in an upcoming issue of Mayo Clinic Proceedings. Formal criteria for the diagnosis has been lacking until recently. While criteria now exist, HFpEF is a complex syndrome with notable heterogeneity. This, combined with a history of confusing nomenclature, has led to substantial uncertainty with regard to the diagnosis of HFpEF. In addition, HFpEF lacks evidence-based pharmacologic therapy, which contributes to wide variation in treatment practices. Considering that HFpEF is very often managed by non-cardiologists, we sought to understand how the diagnostic and treatment practices of non-cardiologists compare to those of cardiologists. We performed a survey of over 1,000 cardiologists and non-cardiologists at the University of Michigan and Weill Cornell Medical Center. Non-cardiologists included hospitalists and primary care physicians practicing in internal medicine, medicine pediatrics, geriatrics, and family medicine. A total of 211 physicians completed the survey, and our survey revealed the following results. First, over 90% of non-cardiologists reported taking care of HFpEF patients routinely. As you turn your attention to Table 2, you will see that most non-cardiologists are not aware of HFpEF diagnostic guidelines. You will also see that non-cardiologists commonly require diastolic dysfunction on echocardiography for a HFpEF diagnosis. Non-cardiologists also commonly required the presence of an elevated BNP for a HFpEF diagnosis, with differing thresholds for that elevation. In regards to the treatment of HFpEF, you'll see in Table 4 that non-cardiologists were less likely to use an aldosterone antagonist for the treatment of HFpEF. HFpEF patients were less likely to be referred to a cardiologist compared to HFrEF patients in Table 5. And you also see in Table 5 that non-cardiologists were more likely to discuss prognosis and goals of care in HFrEF patients compared to HFpEF patients. These findings are relevant for clinical practice for a few reasons. First, our results highlight two important misconceptions regarding the diagnosis of HFpEF. Importantly, the presence of diastolic dysfunction is not required nor sufficient for a HFpEF diagnosis. In other words, HFpEF can be present in the absence of diastolic dysfunction. The European Society of Cardiology diagnostic criteria state that a HFpEF diagnosis requires only one of the following echocardiographic findings: diastolic dysfunction, left ventricular hypertrophy, or left atrial enlargement. Therefore, again, diastolic dysfunction is not required for the diagnosis. The survey also identified that many providers may exclude a diagnosis of HFpEF using a BNP threshold higher than that recommended by guidelines. The ESC diagnostic criteria requires a BNP of only 35 picograms per ml to make the diagnosis, and some argue that no threshold should be used, given that obesity, which is quite common in HFpEF, is associated with lower BNP levels. These findings suggest that an increased awareness of guidelines among both non-cardiologists and cardiologists may lead to appropriate HFpEF diagnoses. In addition to these diagnostic issues, treatments varied in several ways. While aldosterone antagonists are still being studied in HFpEF, opportunities may be present for non-cardiologists to utilize this medication which does have guideline support for use in select patients to reduce heart failure hospitalizations. More importantly, our survey also showed that non-cardiologists are less likely to refer a HFpEF patient versus a HFrEF patient to specialists, as well as to discuss goals of care with HFpEF patients. With the rise of specialized HFpEF clinics, an opportunity exists to improve the care of HFpEF patients through partnerships between non-cardiologists and cardiologists. This is incredibly important considering the high rates of morbidity and mortality in HFpEF that can be due to both cardiac and non-cardiac causes. For more details regarding the findings as well as additional perspectives, please read our manuscript. Thank you so much for your time today.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.